May I call upon Dr. Sharmila Borkar to share her wisdom of pearls on renal replacement therapy. And now I request Indrani Hemant Madam, Madhuri Kurde Madam and Dr. Shri Ganesh Kamath Sir to chair the session. Indrani Madam is Professor of Pediatric Anesthesia at KEM Hospital, Mumbai. She has more than 85 publications under her name. Her special interest in critical care and obstetrics. Madhuri Kurde Madam is Professor and HOD at Karnataka Medical College, Hubli. She has many articles, book and many chapters under her name. Dr. Ganesh Kamath is Associated Professor at GMC Sindhudurg. He is interested in pediatrics, regional anesthesia and airways. Now I request Chairperson to introduce our speaker.
I'm happy to introduce to you Dr. Sharmila Borkar, ma'am. She is an MD anesthesia she has done an MD anesthesia from Mumbai. Currently, she is Associate Professor in the Department of Anesthesia at Goa Medical College. And she has been a PG guide since 2012. She has also worked as a specialist anesthetist in the Kingdom of Saudi Arabia. Madam has been working in Goa Medical College as a PG teacher since the last 19 years. She has been giving talks in many state, zonal and national conferences and presented papers in the International Conference of Pain. And with this, I welcome you, ma'am, to this session. Please proceed.
Thank you, ma'am, for the kind. Wish you all a very good afternoon. My topic is basically, for me, it's more of a theoretical topic, but it's a very important topic for the PGs because it is a MD anesthesia question. Long note can come. And I would be focusing more on the continuous renal replacement therapy because of time constraints and the anesthetic applications for it. So the general term of renal replacement therapy is used to describe all of the currently available approaches to artificial mechanical support of the renal function. So it mostly replaces the endocrine function of the kidneys. It includes traditional intermittent hemodialysis, peritoneal dialysis, which most of us are familiar with, and a variety of other intermittent and continuous therapies. Any hospital admissions, there are at least 30% patients who have AKI and 5% require RRT, and the hospitality mortality can range up to 60%. The term continuous renal replacement therapy refers to a number of such replacement therapies used to optimize, it's basically used to optimize fluid and solute management. These therapies provide better control of intravascular volume, electrolyte balance and uremia depending on the characteristics. So it is defined as a life-supporting treatment that replaces the kidney's waste filtering function or the non-endocrine function in patients with kidney failure. So dating back to the 1960s, the idea of CRRT was conceived, but that time there was no technology or supplies available. As time progressed, technical groundwork for hemofiltration started establishing, and we had ultrafiltration and convection therapies. Later, there were more effective therapies, arteriovenous hemofiltration, which was simple and effective method and was well tolerated by the critically ill patients. Later was developed the continuous renal replacement therapy, which is in vogue now, and lot of machines and development has occurred in this field. So we are all aware, initially it was called as acute renal failure, but now the terminology has changed to AKI. So that is replaced by AKI or the acute kidney injury, which is defined as abrupt within 48 hours decrease in kidney function, which encompasses both injury, that is structural damage, and the functional impairment. It is a syndrome that rarely has a sole and distinct pathophysiology. Many patients may have mixed pathophysiologies which may coexist. And the syndrome is quite common among patients without critical illness also. So as we know, the causes are pre-renal, renal and post-renal. So most of these intrinsic AKI represent true kidney disease. However, pre and post-renal, if it is prolonged, can become a true kidney disease also. So these are the various causes of acute kidney injury. If you see the pre-renal causes, it is mostly related to the impaired renal perfusion. The intrinsic causes could be because of drugs and toxins, which are nephrotoxic drugs, or it could be infections, trauma, tumors, etc. And post-renal is mostly obstructive pathology. Now, there is a AKI classification known as rifle criteria. So, it depends upon the levels of serum creatinine, the rise of serum creatinine and the reduction of GFR and the urine output. So as the creatinine values rise from 1.5% of the normal and the GFR decreases from 25 to 50%, and we know the normal urine output is approximately 0.5 to 1 milligram ml per kg per hour. So if there is reduction of more than less than 0.5 ml per kg per hour within 6 hours, it is definitely a risk to kidney injury. So this progresses to failure if the creatinine rise is more than 300% or 3 times the normal value, and the GFR starts decreasing by 75%. There is another classification, AKI, which also depends upon the creatinine and the GFR values. Both of them end into the loss of kidney function if there is persistent AKI, where there is complete loss of renal function for more than 4 weeks, and this leads to end-stage renal disease, which is complete loss of renal function for more than 3 months. So as you know, any disease can be evaluated by history, examination, laboratory investigations and advanced investigations. So this is the mnemonics for indications of RRT, the vowels A, E, I, O, U. So first is the severe metabolic acidosis. If pH is less than 7.1, hyperkalemia, potassium more than 6.5, removal of toxins, fluid overload which is refractory to diuretics can also lead to oliguria or anuria, and symptomatic uremia. Severe sepsis and MODS also is one of the indications for RRT, where you can remove or adsorb the inflammatory mediators. Now there are different modalities of renal. We are all aware of this intermittent hemodialysis or ultrafiltration or peritoneal dialysis, but there is something known as continuous renal replacement therapy and hybrid renal replacement therapy. So my today's talk, as I told you, will focus more on CRRT. So decision making is a team approach, which also not only includes the patient, the doctors, intensivists, nephrologists, but also the family members of the patient are counseled. Now, how do we plan? How do we know which form of RRT should we use? So if you see, if there are small molecules and electrolytes to be removed, if the size of the molecules is less than, we go for traditional dialysis, hemodialysis. But if we require to remove larger molecules and cytokines, complements, inflammatory mediators, etc., filtration is the choice. And if it's only water, then again filtration is better than dialysis. So continuous renal replacement, in this, it is a gradual, slow thing, but it is continuous. So there is lot of hemodynamic stability. It is predictable control and predictable control of chemistry also, biochemistry, stable intracranial pressure and disease modification by cytokine removal, although it might be a bit expensive compared to intermittent therapies, which is less expensive, flexible timings, rapid correction of fluid overload, and rapid removal of dialyzable drugs, and also minimizes the you can do away with anticoagulation. So a basic dialyzer unit consists of a dialysis solution, tubing for the transport, machine to power the entire process. So this is how it is. Now there are various mechanisms like hemofiltration, hemodialysis, hemodiafiltration. So hemofiltration is basically a convection process where there is ultrafiltration and it removes both small and larger particles, whereas hemodialysis, in this there is a semi-permeable membrane and the use of dialysate, and movement occurs from high concentration to low concentration, used mostly for smaller particles. There is hemodiafiltration, which uses the combination of both. So this is the mechanism. Diffusion is for hemodialysis. Hemofiltration is basically by convection. Intermittent hemodialysis, we are really aware of this, which is usually done in most of the ICUs or in patients with CKD, which is performed 4 hours, 3 times a day or 3 times a week or daily. Then we have the peritoneal dialysis also. Then continuous RRT replaces renal function by gradual and continuous removal of surplus fluid retained in the body. So blood is driven from highly permeable filter. Most of the times it is a semi-permeable filter, uses extracorporeal circuit in veno-venous mode. There could be a pre-dilution hemofiltration as well as a post-dilution hemofiltration. The veno-venous hemodialysis, in this, the blood is driven through low permeability dialyzer, uses extracorporeal circuit and countercurrent flow for dialysate. Now, anticoagulation can be mechanical. So, how do you avoid coagulation? By using adequate size of vascular cannulae. You avoid kinking of the circuit. Blood flow rate should be at least 100 ml per minute and continuous monitoring. And use of pharmacological drugs like unfractionated or low molecular weight heparins. Arteriovenous access, mostly the femoral vein and artery are used. Here there is no pump required, but the disadvantage is the limb can go into ischemia and cause gangrene. Veno-venous access, usually a double lumen cannula is inserted into the femoral or the internal jugular vein. Rapid and consistent blood flow rates, which reduces the clotting, but it is it gives an improved dialysis performance. Although the disadvantage can be air embolism, hemorrhage and central vein thrombosis. Complications include again vascular site malformation, air embolism, circuit blood clotting and fluid and electrolyte imbalance. Bleeding, thrombosis, sepsis, infection, hypothermia is very common, which I will be discussing later. So this is more interesting. If a patient is posted for any surgery who's on CRRT, he is in the clutches of surgery, the CRRT itself and the anesthesiologist. The whole onus falls on the anesthesiologist to make the patient sail through the procedure. So anesthetist should always be aware that CRRT is used to, he has to plan, one should contemplate the use in the operating room. Resources must be available for CRRT in the operating room also. Finally, for the transition, when the patient is shifted from the ICU to the OR on CRRT, logistics should be available for transfer of patient. As any case, we have a preoperative assessment, which is very important. And the primary concern of the anesthesiologist here is the patient's fluid, electrolyte and acid-base balance. He should know that there could be multi-organ failure, mechanical ventilatory support, patient is mostly hemodynamically unstable and maybe on vasopressors or inotropes, and you should be clear about the indications, the goals and whether the goals have been met after CRRT. So assess the metabolic implications, evaluate the coagulation status, especially the platelet functions. Heparin is used mostly as an anticoagulant and it has the impact on clotting can be unpredictable. So sometimes alternative anticoagulants are also used. Now temperature monitoring. Lot of heat is lost during this procedure. So most of these patients are hypothermic. So warming devices and fluid warmers have to be available at any given time if these patients are taken for surgery. However, if the temperature is normal or it is high, then you have to think that the patient might be having some infective pathology also. The therapy will be discontinued before transfer to the operating table most of the times, but sometimes you just cannot discontinue. So it requires an understanding of the process and careful planning. Discontinuation of the CRRT and filter are separated from the access catheter and the circuit is discarded. Once the circuit is disconnected, the catheter should be flushed with heparinized solution, otherwise the whole system will get clotted. And before using the catheter again, the heparin should be aspirated from it. So, transfer of patient, the therapy will be discontinued to transfer. After discontinuation, the anesthetist must have a plan for managing. Now there is no CRRT, so onus lies only on the anesthetist to manage fluid, acid base and electrolytes, review the CRRT orders and clarify the fluid goals of the therapy, electrolytes and bicarbonates. Based on a review, plan for, always planning is very important, anticipation and planning is very important in anything. So, use the cannula used for therapy must be easily accessible. Mostly femoral and internal jugular catheters are used, and internal jugular catheter has a good flow characteristics and it is always easily accessible and can be used. And in the post-operative period, the clinicians managing the therapy in the ICU or the HDDU must be cognizant of the intraoperative course. The flows and replacement fluid composition must be carefully titrated and the patient must be closely monitored. CRRT should also be considered as a therapeutic option in the post-op period. So you might have to, most of the time CRRT has to be continued along with mechanical ventilation. So now let's see how we proceed for anesthesia for emergency surgery. Aspiration prophylaxis is a must. Anxiolysis with small doses of midazolam. Opioids, generally fentanyl is used in increments of 25 micrograms. Never use arteriovenous fistula or graft for venous access. Do not use BP cuff on the site of the AV fistula. So intravenous access can be peripheral or central. IBP is always preferred. Used in increments of 25 micrograms. Never use arteriovenous fistula or graft for venous access. Do not use BP cuff on the site of the AV fistula. So intravenous access can be peripheral or central. IBP is always preferred. Choice of anesthesia is mostly local anesthesia with monitored anesthesia care preferred. Regional anesthesia should be avoided in deranged coagulation, and general anesthesia can be used wherever required. So again, we have to be very modest with all the drugs and dosages. Induction preferably with propofol 1 to 2 milligram per kg body weight. If rapid sequence intubation is required, succinylcholine can be used only if the potassium is not more than 5. But if it is high on the higher level, you can use rocuronium with Sugamadex reversal. If RSI is not required, then you can use cis-atracurium or rocuronium. Alternative techniques without intubation, TIVA, remifentanil, sevoflurane and propofol can be used. Maintenance is with inhalational anesthesia or TIVA, combinations of IV and inhalational, and a short-acting opioid may be carefully titrated. Most important is the fluid management in these patients. So balanced electrolyte solutions, unless the patient is hyperkalemic. Most of the times we use normal saline. If at all we have to use colloids, use 5% albumin, avoid blood transfusion. If at all, use packed cells if the HB is less than 7 grams per deciliter. Remember the glucose control. Maintain it up to 180 milligrams per deciliter. Post-op analgesia, again for these patients, multimodal approach to post-op analgesia like neuraxial, peripheral nerve blocks, wound infiltration with local anesthesia, non-opioid analgesics, but avoid gabapentinoids, meperidine and long-acting opioids, and of course NSAIDs. So to summarize, RRT is an established therapy for AKI. It can be intermittent, hybrid or continuous. CRRT offers better control over AKI and can be employed for non-renal fluid overload management. Careful evaluation, monitoring, management, planning, etc. If it's done properly, along with the logistics, I think any case can be handled well, even if the patient is on CRRT. So blessings from Ma Durga, it is Navratri time. Thanks a lot. I would like to thank the ISA branch MIRAJ-SANGLI. Special thanks to Dr. Vasudha and Dr. Rupali for giving me this opportunity.
Due to lack of time, we will have all question answers if there are any at the high time.
Agree with you. Yeah.
Yeah.
Sure.
Thank you, madam, for the wonderful lecture. And I request all dignitaries on the dais to be proceed towards the felicitation point.